My name's Len Gray, for those of you who haven't met me before. I'm the country lead for interRAI in Australia, and I'm a board member of interRAI and have been involved in interRAI and advocate for its use in Australia for about 20 years now. And I'm pleased to say there's a fair bit of interest in Australia and obviously around our region in interRAI, and this work that we're hearing about today around SNOMED is quite an important piece of work in relation to how interRAI fits within the kind of informatics world, and so I'm sure you'll be interested to hear the talk. So before we proceed any further, I'd like to acknowledge the traditional owners and their custodianship of the lands on which we meet here in our various locations across Australia. We pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country, and we recognise their valuable contributions to Australia and global society. And I see quite a number of people here from New Zealand and from Europe, so very pleased to have you on the call, and this is our way of acknowledging our traditional owners here in Australia. Very important that we do this. Some housekeeping matters. We're going to record this. If you happen to have questions, we can take live questions, but if you have questions you want to put in the chat, by all means do so. We'll be monitoring them as the session proceeds. But bear in mind that we are recording this and it will be available subsequent to this meeting for others to watch. For some time, interRAI internationally has been in conversations with SNOMED International around basically gathering a view about how these systems relate to each other. Both of them are important. SNOMED has a very big footprint in particularly in the acute hospital environment around the world, and it's used in many countries as a kind of way of characterising clinical and related information. And you'd probably all be aware that on the other hand, interRAI has a very big footprint in the aged care sector, and to some extent in mental health and in disability services, and more recently in paediatrics. But the focus of interRAI assessments is very much around functional matters and social context and so forth. And in many ways, it's the information in interRAI systems is complementary to what one finds in SNOMED. However, the intent of SNOMED and interRAI a little different. interRAI is really a set of data with a whole suite of decision support tools attached to it. So in that sense, it's a kind of an assessment and care planning tool set, whereas SNOMED is really a terminology set. So obviously there's a useful and important conversation going on with SNOMED around about how these systems should and could relate to each other. And I think we're getting to the view that they should. And the question is, should it be, is it possible? And that's to some extent the work that Teyl, who's about to present, and her colleagues have done, helps to answer the could question, and then of course there's a should question around that. So Teyl works in the Queensland Digital Health Centre and has, along with her colleague Josh McRae, basically done the bulk of the work to prepare the paper that will be associated with this talk, and she's going to now present the findings of her work, and I think she's done a great job. You'll see, you'll be able to come to that view, I think, at the end of her talk. So I'm going to hand over now to Teyl. She will tell you all about the work that she's done. So thanks, Teyl.
Thanks everyone for coming today. As Len said, my name's Teyl. I am a research manager at the Queensland Digital Health Centre. And I'm really excited to share with you this work that we've done today around enabling connected care through mapping aged care clinical concepts to SNOMED CT. And I want to thank the team that's been involved in this. So Josh, Jody and Claire from Queensland Digital Health Centre, Len, Murray and Ron from CHSR, Kylan from CSIRO and Paul from Queensland Health as well. And yeah, especially my colleague Josh was supposed to be here to present today, but couldn't make it, unfortunately. So I will do my best to present and answer any questions that you've got. Okay, so as most of you on this call probably know, care recipients in aged care are increasingly transitioning between care settings. So that might be from residential care to hospital care, or residential care to general practice and back again. And these times of care transitions are a time of high risk for the patients, because the providers obviously need access to accurate clinical information in order to provide safe and appropriate care. However, the health information systems that support these different care settings have evolved in isolation, and that means that they don't communicate well between each other. So this lack of communication between those settings means that information isn't being shared effectively. So that might mean that data isn't being shared at all, or data is being shared through inefficient means, such as, static PDF documents, or maybe even that care recipients have to take on the role of sharing the information themselves. And obviously, for the care recipients, that can be quite frustrating to have to repeat information about their diagnoses, their conditions, their treatments. Or additionally, the care recipient might not be in a state to share that information or might not know all the information. And so these factors can result in inaccurate and incomplete information. And in turn, that then increases the likelihood of medication errors and adverse events. Additionally, care recipients in aged care often have quite complex needs, so they might have quite a few medications and they might require support for functioning and their well-being. And this further increases the risk caused by inaccurate information. So in order to improve safety and outcomes at the time of transition, we really do need technologies that bridge the gap between the different healthcare settings. So in order for information to flow effectively between clinical settings, interoperability is required. So what does that mean? Interoperable systems are just systems which have the ability to exchange information and to use the information that's being exchanged. And one important element of interoperability is semantic interoperability, which means just having systems that speak the same language. And a key strategy to enable semantic interoperability is to use standardized terminologies across systems. As Len mentioned, one of the most widely used and comprehensive standardized medical terminologies is SNOMED CT. SNOMED is widely used internationally. However, it's more often used in acute and primary care settings and less commonly used in aged care settings. And because SNOMED CT wasn't developed in the context of aged care, it can mean that it doesn't easily incorporate many of the important concepts for aged care settings. So that leads us to our research question. In this piece of work, we were looking to answer the question, is it feasible to map aged care clinical concepts to an international standardized clinical vocabulary? So let me go into a bit more detail about what we did. So in this study, we were looking to map, we were exploring whether concepts from interRAI could be mapped to SNOMED CT. And sort of as Len said, interRAI is obviously a system of assessments that's used in settings where vulnerable people receive care, most notably aged care, residential care, and long-term care settings. And yes, as Len alluded to as well, the data elements in interRAI are tailored to those settings, which can mean that they include a high level of granularity to capture that sort of functional assessment. And yes, interRAI obviously has a large international footprint across Europe, Asia, Oceania, North America, and is most notably used in the residential and community aged care settings. On the other hand, SNOMED CT is a controlled medical terminology which aims to provide a common language for clinical and data documentation. It was developed in the context of primary and acute care and is the most widely used standardized medical terminology globally. As Len mentioned, you can see that these two systems serve different purposes, but can definitely be complementary as well. So I want to tell you a little bit more about the interRAI data elements we looked at in this study to give you a sense of their complexity. So obviously this was a feasibility study, so we couldn't map all interRAI elements or even an entire form. So instead we focused on a representative subset of 8 assessments, which were common between 2 interRAI forms, being the long-term care facilities assessment form and the home care form. And so I'll share a few of those items that we selected to give you a sense of what the source data looks like. So one of the items that we considered was this one here. So the interRAI form is structured in sections. So this fell into the cognition section. And then we had an item here, which was memory/recall ability. And then there was a sub-item within that item around short-term memory. And then when a clinician's doing the assessment, they have 2 possible answer values they can choose from. Yes, there's memory, yes, memory is okay, or that there's a memory problem. So that example is fairly straightforward. The next example comes within the communication and vision section, and the item here is making self understood. In this case, we've got no sub-item. We go straight from the item level down to the answers. And you can see the answer structure here gets a little bit more complex and granular. So here we've got 5 different answer values that the clinician or assessor can choose from. So we've got understood, usually understood, often understood, sometimes understood, or rarely or never understood. And then my final example here is looking at functional status assessment. So again, functional status is our section. The item is activities of daily living, self-performance. And then in this case, the sub-item we were interested in was walking, how they work between locations on the same floor indoors. And in this case, the possible answer values get even more complex. So here we've got 8 possible answer values, so representing 8 different levels of granularity in terms of differing levels of ability and independence. So as I mentioned, for this study, we aim to choose a representative of 8 interRAI assessments, which span these 3 sections of cognition, communication, vision, and functional status, as well as 1 diagnosis item and 1 procedural item. And in the feasibility study, we aimed to map all items, sub-items, and answer values. So that's items, sub-items, and answer values, which gave us 50 mappable elements in total. So how do we do the mapping? So the Australian Digital Health Agency publishes SNOMED CT mapping guidelines, which we followed for this studies. And there's a number of steps as part of those guidelines, which the report goes into more detail about. But for today, I'll just give you a high-level overview of the process. So starting down here at number 1, the first thing we did was we converted the interRAI data elements into a mapping ready file. So that was just sort of a reformatting exercise to make the data easier to map. And then we imported that mapping ready file into this application here called interSECT. And so interSECT is a prototype application that my colleague Josh developed for this project. And it was really useful in allowing us to document all of the proposed maps and all of the information that is suggested in the ADHA mapping guidelines. So the first step after we had the data in interSECT was for the mapper here to access the mappable element through interSECT and search that in SNOMED. I've got a bit of a more detailed view here. So yes, as the mapper, we selected one of the elements that were part of our feasibility study here in interSECT. And then we searched the SNOMED CT catalog using the CSIRO tool Shrimp. For those of you that don't know, Shrimp is just a really great tool that was developed by CSIRO, which provides a very easy to use user interface for the SNOMED CT catalog, which is expansive. And so we would search the source terms in SNOMED CT as well as other, related words. And we would record those matches or those possible matches or possible maps for each of the elements here in interSECT. And there was 2 mappers, myself and Josh, who were doing this work. We each completed half of the elements and then reviewed each other's work. And then after that step, then we had a clinical validation step of the proposed maps. And so this was done through an SME committee comprising of the 2 mappers, myself and Josh, our mapping manager, Jody, as well as 2 clinicians, Len and Paul, who have extensive experience in aged care, as well as obviously Len has extensive experience in the interRAI systems as well. So jumping back into the interSECT application. So in the clinical validation meeting, we discussed the possible and recommended targets, and we as a group agreed on the final mapping. Recorded that here. We also agreed on the target relationship type, so whether we considered the interRAI to SNOMED map to be an equivalent map, or whether it was a broader mapping, a narrower mapping, or an inexact match. Then we also recorded whether the mapping was a 1-to-1 mapping, a 1-to-many mapping, or a many-to-one mapping. And we recorded the type of concept we were mapping to in SNOMED. So that's whether it was a finding, a procedure, an observable entity, etc. And then finally, we also recorded the conversation that happened during the clinical validation meeting down here, as well as the date that the decision was made. What did we find? The high-level takeaway here is that all of our 50 interRAI mappable elements had a feasible match in SNOMED CT. So that was great news to start off with. In terms of the target relationship type, we found that just over 2/3 of the maps we considered an equivalent match. About a quarter were considered broader, and then we had a few inexact and narrower matches as well. In terms of the target concepts that we were mapping to in SNOMED, about just over half of them were findings, and then we had a few of the observable entities, procedures, disorders, and regime or therapies as well. And then looking at the target map patterns, most of the maps were one-to-one mapping, and we had a few one-to-many and a couple of many-to-one maps as well. Despite the fact that all of the elements did have a feasible match, some of them were far from straightforward. So I'm going to talk you through two specific examples now, which show you some of the complexities that were involved in this mapping process. All right, my first example here is around cognitive skills for decision making. So this was an interRAI item. Cognitive skills for daily decision making, making decisions regarding tasks of daily life. So this is the description in interRAI. And through conversation in our SME committee meeting, we determined that this interRAI element or this interRAI item includes 3 distinct ideas. The first one is around cognitive function. The second one is around the care recipient's ability to make decisions. And the third concept is that those decisions relate to daily life. So unfortunately, there isn't a single SNOMED CT concept that captures these 3 different ideas. So instead, we had to map the one interRAI item to 3 different SNOMED CT targets to capture those 3 distinct ideas. So you'll see here we've got one around skills relating to cognitive function, ability to make decisions, and activities of daily living. In our SME committee meeting, we determined that this was an equivalent match with that one-to-many mapping. Yes, so yes, it's a feasible match, but it's important to note that there are complexities when we're using one-to-many mapping, where we're mapping a single interRAI item to multiple concepts in SNOMED. There's some complexities in how that data would be transferred to an EMR system and how that data would potentially be interpreted in the end at the EMR system as well. Okay, the next example I want to show you in detail, which is to demonstrate the complexity of the interRAI answer structures. So this is the example I showed you at the beginning relating to patients or how patients are able to walk on a flat surface or walk on the same floor indoors. So in this case, we had 8 potential answer values representing different levels of ability and independence. And capturing that corresponding level of granularity in SNOMED posed a little bit of a challenge. So while we had 8 different levels of granularity in interRAI, we found that SNOMED only really captures 3 different levels of granularity in the findings. So that's they are either able to walk on the flat, they have difficulty walking on the flat, or they are unable to walk on the flat. So the first thing we did was to map our source data to those 3 levels of findings that show up in SNOMED. So we found our first 3 answer values indicated that the care recipient was able to walk on the flat. The next 4 answer values represented that the care recipient had some difficulty walking on the flat. And then the final answer value suggested that the care recipient was unable to walk on the flat. And then we added in one more finding here because this second answer value suggested that the care recipient needed and was using an aid to walk. So there was a finding for that in SNOMED as well. So after doing this, we still wanted to see if we could replicate a more granular level of detail, such as that captured in interRAI. So we decided to investigate using qualifier values in SNOMED CT. And qualifier values are just a specific type of concept that is used in SNOMED CT, which allows us to refine or further define other concepts in SNOMED CT. So we found that there are qualifier values of independent and assisted. So that helps us understand whether they can walk independently or whether they require assistance. And we also have qualifier values around mild, moderate, significant, and maximal. So we added these in as well, as that allowed us to capture the level of difficulty that the patient had walking on the flat. So that allowed us to sort of, create more granularity than was inherent in just the finding values. So after adding those in, we did have 8 different levels of granularity. However, even with those 8 levels of granularity, we still determined that most of these matches, 5 of these, we considered them a broader match. So we weren't able to capture the level of detail that's in interRAI, such as, this one here with extensive assistance is around, having 1 helper versus this one is having 2 helpers. So we weren't able to capture that level of detail, but we have still got 8 levels of granularity in our mapping here. And again, I do want to call out that similar to in the one-to-many example I showed you before with the mapping, using qualifier values can also introduce some complexity in how the data is transferred and interpreted in a target EMR system. So definitely something to keep in mind. Okay, so that's what we found. I just want to call out a few little things to help contextualize those findings. So as you probably all know, older populations are continuing to grow, and hence there will be a growing population of people requiring long-term care and transitioning between care settings. So getting this right, having access to accurate information in different care settings is increasingly important. In this feasibility study, we were able to show that it was feasible to map concepts from an aged care setting to a standardized vocabulary. However, we did this on a relatively small sample of elements, so it's really important that we need to do further work to expand this. Our study also focused on the first part of the interoperability journey, I guess, which was mapping from interRAI to a standardized vocabulary. There is significant further work required to map to figure out how we take those SNOMED codes and integrate that into an EMR. And this is especially difficult, as I mentioned, or especially challenging in terms of those one-to-many mappings, or where we're using qualifier values in our mappings as well. For this study, obviously, we were focusing on using interRAI, which is an established system of assessments. But it's worth noting that future systems should be, and in a lot of cases are, considering incorporating interoperability at the design stage. So they are including standardized terminologies, as well as data exchange technologies like FHIR at the design stage to help future-proof their solutions. So in summary, we believe that this work advances efforts towards interoperability between aged care settings and other care settings by providing a common language that enables effective and efficient data sharing to underpin connected care between those settings. And that is everything from me. Thank you guys so much. And thank you for the work, for the team that was involved in this work. And I look forward to any questions or feedback that you guys might have.
Thank you. That was really well presented. Thanks, Teyl. Right. So has anyone got any questions?
Thank you, Teyl. That was very interesting. And I guess at some point along there, would you be looking at how things would map to the outcomes? So the scales and the clinical assessment protocols of the interRAI assessment? Or is that quite different?
Yeah, obviously the scales, there's a whole lot of outputs for those who aren't familiar with interRAI. There'd be, a massive number of, it wouldn't be massive, but numerous, 30 or 40 outputs of an assessment like the long-term care or home care assessments that probably more actually would also need to be kind of managed somehow in terms of how they'd be configured for interoperable status. Whether SNOMED can do that or whether it needs to be something like LINC or something, we have to think about that as well. There's a lot of work to be done here, a lot of thinking. But yeah, obviously the issue here is if data in SNOMED configuration translated from interRAI is ported across to another provider software system, how does that get reassembled into a meaningful kind of representation of an assessment, for example? It won't back translate perfectly. I think Teyl and I have talked about this a lot. You lose something in the translation, and back translating is not really feasible. It's kind of could be done, but so there are issues about this. But I think at least we've figured that we can represent interRAI fairly well in a SNOMED environment. I think that's pretty clear from this work. Do you want to add to that, Teyl?
Yeah, just to say also, I guess the thing that I didn't mention in the presentation is one of the first recommendations in the ADHA mapping guidelines is that we have a specific use case. Obviously, for this exercise, we're looking at interoperability more broadly, depending on the very, when you have a very specific use case, as Len said, how that data then gets sort of integrated into the EMR might change. So, for example, one of the items we looked at in this feasibility study was whether the patient had depression, a diagnosis of depression. And there's sort of, yes, they've got a diagnosis, and then there's different varying sort of levels. So, and one of the other options is obviously, no, they don't have a diagnosis. So depending on your use case, the absence of a diagnosis might not be a useful piece of information to transfer. And similarly, with some of the assessments that we looked at, the findings, so the fact that the patient can't walk on a flat surface, for example, might be useful, but the fact that the assessment was done might not actually be a useful piece of information. So I think depending on the use case, that sort of next step integration piece might look a little bit different.
I'm sorry, I've got to follow on from that. So, and I'm not familiar with SNOMED at all. So is it simply the assessment, or does it have an outputs or a care planning module or anything like that?
There's a number of different sort of types of concepts. So I didn't go into this in much detail, but there's a bit more in the report. So things like the finding type of concept in SNOMED is generally sort of like the outcome, I would say. And there's things like observable entities and procedures, which are more of a description of the assessment itself. And then in terms of care planning, so there are other types of concepts in SNOMED that relate to regimes or therapies. So we did also include one of those in our feasibility study, which was around the toileting. And so we were able to map that to some of the regime therapy concepts within SNOMED as well.
However, Sally, the SNOMED is, and correct me if I'm wrong, Teyl and others, but essentially it describes everything. It's just a set of descriptors. It's like a dictionary. It's not a sentence, and nor does it have logic that produces computerized outputs. That's up to third parties to use the SNOMED terminology or language to then create applications. And of course, many organisations do this at national or even at local levels. A lot of work goes into that in acute care using the SNOMED infrastructure to create product. And that's where interRAI is different. interRAI is both data elements, albeit complicated data elements, but also it produces a lot of outputs through the use of a wide range of algorithms. So these things are not equivalent concepts. They're overlapping, I would say, would be a fair way to describe it. But interRAI was built mainly as a decision support system, and I think it doubles as an MDS in minimum data set in many jurisdictions, whereas SNOMED is a kind of universal. It's intended to be a universal set of descriptors of clinical and care-related phenomena. So they're not the same thing. But there's plenty of people on the call that could answer these questions better than me. Forgive me if I'm not describing this correctly. This is my humble interpretation of SNOMED. Other people wish to comment or ask questions? Murray?
Yeah, just to say, in my limited understanding of SNOMED, and what helped me understand it was that it seeks to resolve kind of issues of ambiguity, so that you can have a SNOMED code associated with a kind of unique clinical or care-related concept that gets around variations in naming, which could be language-based, they could be regional-based, or they could be setting-based. So folk in a particular workflow might call a particular clinical or care concept, heart attack, and then in another place they call it myocardial infarct, and then in another place they have a different language, a non-English language version of that. But in SNOMED it'd have a unique code, and so that allows you to transfer that information and maintain that meaning. And in Australia they have a quite a good setup built by CSIRO, where the kind of collection of codes and terminology is centralized, and healthcare users can, oh yes, so Lisa's just popped that into the chat. They can download, the most up-to-date dictionary of terms for their use. And it's because it's centralized, you don't need to kind of keep your own copy, and you're using version 2, but the GP is using version 1.5. It gets around all that problem. There's a kind of centralized, and SNOMED controls the kind of versioning of terms. And so it just gets around that problem of what exactly do you mean when you say circulating blood cholesterol, LDL level, that kind of thing.
Thanks, Murray.
No worries.
I think Sally wants to say something.
Oh yes, I'm another Sally from New Zealand. I'm in a working group in with University of Auckland where they're doing some work on using artificial intelligence to pull out a narrative summary from the interRAI home care assessment and LTCF. And I'm just wondering how that would match with this and whether Australia is aware of that work. You look as though you are, Teyl. And yeah, just a question, because they're doing another focus group tomorrow with some of my colleagues. I work for a community provider on the utility of the narrative summaries that they've pulled out.
No, I wasn't aware of that, Sally. That's really interesting. I was curious as to what the proposed use case is for the narrative summaries.
I think, because I've been around interRAI for about 20 years, I really love the language and the terminology, and I don't find it too difficult to understand. But apparently a lot of people either don't make that, other health professionals who don't use it on a day-to-day basis. So it would be, say, in New Zealand, where our needs assessment service do a home care assessment, and then our nurses or RHPs in community care providers meet the client and whānau and put in a package of care under a bulk funded model in the community, where we determine along with the client and whānau what services the person needs and under a restorative model. And so that's we've got a slightly ridiculous system in New Zealand where the NAS does the assessment, an RHP there does the assessment, but another nurse actually puts in the service and forms relationship again. So that would be the one concept. Or for long-term care, if a person did have to be admitted to acute hospital care, that would be a narrative summary. That would be my understanding.
Yeah, interesting. I mean, in terms of, I guess, it's interesting. I feel like the piece of work that we're doing is, mapping to SNOMED, I guess, is to some extent the opposite of a narrative summary in that it's trying to create, a standardized, it's translating into a clinical terminology as opposed to a narrative, more human understandable terminology. But definitely can see the value in both of those pieces of work for, as you said, for different use cases.
Yeah, I think the utility also, there might be different levels of summary if it's going to a health professional or if it's going to the client and their family.
Mm-hmm.
But if you'd like me to put you in touch.
Some of the reading text, I see Michael Costello's making comments about other work being done in this world of free text and making use of it. One of the big problems, I'm speaking as a clinician, is if people don't think about the concept and don't write anything down, there's nothing to interpret. And if clinicians are completely oblivious to the fact that walking is important to an individual and they only ever see them in a bed, they write nothing in the free text to interpret, and you just left. So that to some extent these coded responses, forced decision making around these kind of phenomena that are not familiar to a lot of people really does make sure that these important concepts get represented in the record. So obviously a mix of free text and hard-coded information is the substrate of getting the best appreciation of a person's needs. So AI overlaid on these systems together with any free text would be where I think the future probably lies, but we'll see. That's where I think it's going to go myself. Did anyone else want to comment? Ask a question?
I was going to make a comment, Len. I'm not sure if you can hear me.
I can.
Yes. So this just goes back to what Sally has been describing. The context that Teyl described today was mostly around interoperability, but one of the use cases that can emanate from this piece of work is allowing interRAI data to be combined with other data sources. So once the data is coded using SNOMED CT, it allows it to be combined with other sources that are coded using SNOMED CT. to advance analytics that can include machine learning, artificial intelligence, etc. So there's a bit of complementary work, a bit of complementarity between what we've done here and what maybe those people in New Zealand that you describe have done.
It's a good point, Ronald. In an interRAI assessment, for those, some of you know them terribly well, others not at all, but interRAI assessments have a big emphasis, and their strength is really around the functional and psychosocial and contextual information. They also do contain drug information in some instances. They also have information around diagnoses and so forth. And I can speak from interRAI's perspective without incurring anyone's wrath, I think, to say the way diagnostic material is coded in interRAI assessments is not to the standard that SNOMED can deliver. So whereas I think the functional information is superior to what SNOMED can deliver, and I think we've seen Teyl's kind of shown us that. So working out how to make these things work together is the key to really good systems. Historically, interRAI, has had its place in aged care mainly, and it has been the centrepiece of data collection or coded data collection for the long-term care sector, and without really ever touching some of the concepts that are really preeminent in acute care, for example. So one could imagine using SNOMED technology in long-term care, particularly for those data items in an interRAI assessment or anything in the long-term care setting where SNOMED is superior. So figuring out how to do this, have these two systems working side by side is going to be an important use case, I think. I personally think, this is not speaking from interRAI's perspective, it would be good to code up the whole interRAI assessment from get-go using SNOMED codes. So when it's coded up by a software vendor, there are codes for SNOMED already present out of a dictionary, similar to the one that CSIRO curates, and therefore it's ready for translation, albeit with the kind of loss of granularity that you lose sometimes. So there's a lot to be thought about. Teyl, I wonder if you could comment about FHIR and other interoperability standards and how that relates to SNOMED and what the implications of this work might be for how interRAI systems relate to a standard like FHIR.
Yeah, certainly. So FHIR is obviously the data exchange technology that's being very widely used in Australia and other places as well. And so I believe that CSIRO are doing a lot of work that essentially once you've got something into a SNOMED CT form, how FHIR then sends that to an EMR is essentially a process that they're automating, and they've created that technology. So once, as you said, Len, once we've got the data into a SNOMED form, that does open up a lot of opportunities for us in terms of interoperability with other systems. With, I guess, just to call out the limitation that I mentioned in the presentation around where we're doing one-to-many mapping and using qualifier values, I think from what I understand of speaking to CSIRO, there's still working on exactly like sort of how those more complex cases would be captured through FHIR and then integrated and interpreted in an EMR as well. And also thank you, Ron, for your comment earlier around the other use cases as well that I didn't mention. So obviously interoperability is very important and was the main use case that we considered, but there are lots of other benefits of standardizing this data into a standardized terminology as well. As Ron said, analytics, we can then combine this with other data to do, research across international systems or systems that use, standards other than interRAI. And another use case is also around regulation. So we can, once we've got the data into a standardized format, reporting then becomes a lot easier as well.
I'll just add to that, Teyl. So the use of FHIR for transferring data between two systems in some cases requires that you have to use a terminology system. And in most cases, that the suggested terminology system is SNOMED CT. So in order to be compliant, if you are transferring certain types of data, you have to attach those SNOMED CT codes for compliance with FHIR specification. So it's absolutely necessary that this work has to be done. if in the future we are looking at using FHIR for transferring inter-RAI data.
Thanks, Ronald. Murray?
There's just quite a few things in the chat that I'm reading that are interesting. I'm just wondering if we should run through some of those. But I haven't been able to keep track of which have been answered and not because I've been listening and reading. But I know Jana had a question at the top of the chat pile, which I don't think has been answered, about the app.
Yeah, so what Jana's saying is, have you published this POC app somewhere? Will the mappers presented today be accessible to the community? I can probably answer that. The report will be published on our website, the CHSR website, sometime today or tomorrow. When it's up, we'll email everybody who's registered for this seminar, so you'll be able to access the report. Some of you have already seen the report. There are two versions of the report, I should let you know. One is, we have a kind of attenuated version that's publicly available, but because inter-RAI items are copyright, we are only offering the full technical report. In fact, there's a big table that displays the absolute detail. So if you're interested in the absolute detail, which is fairly boring except to informaticians, you can request the technical version and we'll send it to you. But most of the useful information is in the general report that's freely available. So that's, I think, Jana, is that answering your question?
Yeah, fantastic. Thank you very much. We'll look forward to the report.
Yeah, no, well, if you want to see the technical, the final mappings, that's which exposes the absolute detail of all inter-RAI items. It's there.
Yeah,
anyone can, you can buy a copy of the inter-RAI assessments, of course, from the inter-RAI website, or you can, if you want to email one of us in the inter-RAI land, we'll send you a copy of the data schedule. We do that quite often, but we don't put it in the public domain because of copyright considerations. Who else has got a question? I think.
So, Len, just to jump in, sorry. Lisa put a question directly to me, which I think was a really interesting question and would be good for the non-inter-RAI folk in the audience to hear. And this is about whether inter-RAI assessments or systems have an overarching outcome. And I think they do, but I'm not a clinician and you are. So maybe you can explain for the various populations that inter-RAI serves, whether they are older folk or whether they are people with mental health challenges or children, what is the overarching outcome of applying an inter-RAI system to those folk? The inter-RAI people talk about these various outputs that the assessments can support, risk screeners or scales or flags for further follow-up. But in my answer, I said to you that you're seeking to understand the person's kind of functional capacity, both in what they can do and what they might need help with, their psychosocial capacity, and then that supports your ongoing care planning with them.
Yeah, like I was thinking particularly, Len, from an aged care perspective. So I don't know about the other populations that are represented through these inter-RAI assessments, but I'm thinking more like the home care and the long-term functionality assessment itself. I was wondering if there is an overarching outcome assessment linked to the tool that you could try mapping to SNOMED and using a FHIR standard to sort of transfer that outcome assessment into a record.
Okay, I think somebody asked, I think it might have been Sally, about the product. So basically, this is kind of inter-RAI 101, forgive me. There's a set of clinical observations for the most part, and then there are a suite of algorithms that generate what we call outputs. So the outputs are typically things like risk screeners, for example, risk of falls or risk of developing a pressure injury. There are diagnostic type screeners, probability of having dementia, probability of having delirium. There are composite scales like ADL scales that take all the various dimensions of ADL. So they can be used as outcome measures, of course, when you before and after type scales. There's mortality risk scales, frailty type scales and things like that. And then there are what we call collaborative action points, or CAPs, which are prompts for care. So these identify individuals who have certain characteristics that suggest they are at particular risk of decline, and a prevention strategy is available, or they've got a problem for which a treatment or management plan is appropriate. So these would be things like the person's found to have depression through a screener or whatever. They would be targeted for treatment. A person has a high risk of pressure injury, they would be targeted for risk mitigation. So for all of those outputs are numbers of scales of one sort, or they're dichotomized outcomes, risk, high risk, low risk, or high, medium, low risk, those kind of things. All of those measures are what I think Sally was asking about. How do they get characterised for interoperability purposes? And they do need a solution. I'm not sure that SNOMED has that answer, because SNOMED doesn't really deal with scales all that much, but Teyl might want to kind of say something about that, but some other systems do. The other thing that there is a set of core interRAI items that are in every assessment. That's the way interRAI builds its solutions. It basically has a suite of standardised items that are scored on everybody that has an assessment, regardless of context, pretty much. And then there are these kind of setting or context or setting specific kind of measures. We would probably start with, if we were going to code up everything in SNOMED, we'd start with these core measures that are appearing in every assessment. They're the most important measures. So there's a lot to think about. And as Teyl will say, what's your use case? What are you trying to do? The way you code it up might be influenced by the use case, which items you code up, and so forth. So, this is quite a discussion that's kind of happening with SNOMED CT, and I think we've concluded with SNOMED International that this can be done. So the discussion's moving away from can we do it to should we do it, and how should we do that? Who would make the investment? It would take Teyl and her group a long time to do 4,000 items. Although the more you do, the quicker it gets, and of course you start repeating yourself, but it would be quite a job to do the whole thing. So that's something we're collectively thinking about. We're getting close to time. Somebody asked about what is SNOMED CT?
I think that was Lisa put in a link to everyone, which explains what is SNOMED CT.
Yeah.
Thank you, Lisa.
Is there any final questions or comments anyone would like to make? If not, well, as I said, the report's going to be on our website in the next 24 hours, I believe, if it's not already there. And otherwise, but nonetheless, we'll send you a link to the report, and hopefully you'll find this useful and help us guide our thinking about investing in more of this, extending this work. But at this stage, we've got enough information, I think, to know what's possible. So now it's a matter of thinking about what should be done rather than what could be done. The only other thing to wrap up, just to update people on where interRAI is at in Australia in particular. There's a couple of important projects happening. You would have heard about the Smart on Fire app development that the Digital Health CRC is building, which will be essentially what I call an engine, which contains the interRAI LTCF, long-term care facility system. It will kind of collect the data. It will calculate all the outputs and configure them ready for interoperability to a third party. So it's going to be a really interesting project to see how that evolves. It's a proof of concept project. It will be done by the end of the year, hopefully. What will happen to it after that will be a matter for the CRC, but it's to demonstrate that this can be done, and it would be very helpful for interRAI to see that product. There are about 4 or 5 vendors in Australia that are either building or are interested in producing an interRAI solution for long-term care now, and a couple of them have licenses, and so they're obviously constructing these solutions in advance of any government decision to use interRAI as an MDS or otherwise. And so we're obviously trying to support them in this work. The more vendors that do this kind of work and make the product available, obviously it makes it accessible to a lot of people. And it's much easier to make judgments about its value when you can actually see it working, as opposed to pieces of paper and Len Gray rabbiting on for hours about how good it is. So we're pretty optimistic about the way things are moving at the moment. Finally, we have another webinar on the 9th of October. You'll get notices about that. We're getting some folks from Alaska to tell us about developments with interRAI in Alaska. Alaska's, as you would gather, a state with a very dispersed community and in some respects has lots of issues common to those that we see in northern Canada and also in outback Australia, and how they're proposing to implement, I think, the interRAI home care and probably the interRAI LTCF will be very interesting. And so we've got some folks telling us their story. They're in that kind of early phase of development at the moment. And I think that will be interesting for us to hear how they're going about it. So I'd be very keen for you to come along if you're interested in that way of thinking about interRAI. Finally, thanks, Teyl, and for that matter, your colleagues at QDEC who did this work. I think my impression is the quality of the work was superb, fabulous tool sets. It's done to a very high standard, and therefore it's a very respected piece of work, I believe, and we have to thank you for that. Fantastic.
Thank you. Thank you. It's been a great project.
Yep. Thanks for everyone coming along, and we'll see you again soon sometime. Thank you. For those of you listening to this conversation who may have further interests in interRAI systems, please visit our website, interRAI-au.org.